Wonderful, thank you. And thank you to the jury and everybody else for continuing to be with us this afternoon. I don't know about you all, but my brain is getting really full today, but this has been exciting and been a lot to learn. And Patricia, I love that we just got that walkthrough with the offender. I think that that's just really lovely that we remember who we're here talking about. So thank you for that. I'm going to take us into treatment a little bit now, so a little bit of a shift, and we're going to think about the individual within the system and what does that look like and how do we respond in a way that is appropriate. So research into intervention has demonstrated that punishment alone does not deter behavior. So just simply having the existence of a system or a criminal justice system doesn't change behavior. And in some cases, what we see is an increase in recidivism. So we really need to think about the way in which our system is providing services to individuals when they're incarcerated so that we are seeing a reduction in reoffending as opposed to an increase in reoffending. I think one of my core messages today, and the thing that I want to come back to a few times, is the idea of simply doing something within the justice system is not doing a good thing. We can actually do harm, and we can make it worse. And so we need to be conscientious about the approaches that we use, and we need to be engaging in research efforts in order to determine whether or not what we feel might be a good approach or what we think might be a good approach really is a good approach. Sometimes what feels intuitively good or would make sense for me is actually not what's going to reduce reoffending rates. And so that's one theme that you're going to hear a little bit from me as we go forward. One of the things we know about interventions when we're working within the justice system is that they appear to be more successful when they're based on an individual's specific level of risk, when they identify an individual's needs, what kind of things do they need, and when we then approach and manage those needs in a way that allow them to change and evolve their behavior into something that is more pro-social or adaptive. Within the justice system, this model of thinking is referred to as a risk needs responsivity model. And so I'm going to speak to you a little bit through the lens of this justice model, talk about it a little bit in terms of how it applies within the justice system to correctional populations in general, and then what's unique about the model for the FASD population. So the risk principle is our first principle. And this principle talks about the predictionability of criminal behavior and essentially is saying who needs the most intensive services. When we're talking about risk, we're not talking at all about why somebody does what they do. So we're not saying why is somebody at more risk. We're simply saying, is this individual more likely than the person next to them to commit another offense? That's what we mean when we're talking about risk. We know when we talk about risk that how much or how intensive the treatment that we provide needs to be tailored to risk. So when we have an offender in the typical offender population who is low risk to reoffend, and so they've been determined to be low risk to reoffend, and we provide them with a low level of treatment, then their risk of reoffending is about 15%. However, when we give a low-risk offender an intensive treatment, more treatment, they get worse, and they're more likely to reoffend. So we need to match that level of treatment. On the flip side, if I have a high-risk offender and I give them a low level of treatment, I see reoffending at 51%. They're much more likely to reoffend. If I give them intensive treatment, so a high-risk offender gets an intensive treatment, then they are less likely, or 32% they're reoffending. So tailoring that intensity of intervention is really, really important for what we do. How much we invest in that intervention has to be matched to that risk level. So the next question, if we can push the right button, is what is the risk to reoffend in FASD? Because understanding that, and we're talking about general population FASD, not the individuals here. Individuals, we certainly need to assess individuals in a one-by-one way. But when we look at the population as a whole, the risk to reoffend is higher than it is with other populations. What that means is when we look at a group of offenders, and Dr. McLaughlin, who's here, has actually conducted this study, she found that offenders aged 12 to 23 were more likely to reoffend or reoffended at a rate of 72%. as compared to non-FASD offenders who reoffended at a rate of 44%. That's a significantly higher rate of reoffending, which characterizes this population as being at higher risk of reoffending. The offense types were generally the same, and in fact, the FASD group engaged in significantly more violent offenses. Now, we're not asking why yet. We're just simply saying this group is at higher risk of being violent, and they're at higher risk of reoffending within the justice system. They also recidivated or reoffended sooner, so 24 weeks as opposed to 32 weeks. So they're also getting into trouble faster than the other groups. So this group is definitely at much higher risk of reoffending. This tells us that we need to provide more intensive support to this group if we are going to meet their needs, according to the research out there. High-risk offenders require high-risk intensive response strategies if we're going to have success in helping them get out of the system. We just actually, Dr. McLaughlin and myself, we said, you know, let's look at the study that she did, and we were listening to Dr. Jacobs' talk this morning about the numbers, and we actually just ran the numbers, because if we're going to suggest that we need more intensive treatment for this group, we wonder what the cost difference is. So we just used Dr. Jacobs' numbers that he presented to us in such a lovely presentation this morning. And in running the numbers from the study, found that the FASD individuals cost about $10 million more in that age bracket of about 11 years. So not even a lifetime of offending. So there's certainly a greater cost with this population. It would be great if we could turn that into treatment spending as opposed to reoffending. The needs principle, the second principle. This is the principle that says, what do we need to treat? So this is when we start to get to a little bit more of what is going on for this individual that we need to tailor or target our treatment towards. The things we know about FASD is that they have a distinct need profile. So the needs that they have are greater than the needs of the population that are typically within the justice system. They have more needs. They have all the same needs, and they have them all to a greater extent, and they have more of them. A couple of examples: the experience of physical abuse in the FASD population within the justice system, we're just talking about within the justice system here, is at 62% physical abuse as opposed to 34% for the criminal population who is not FASD. That's a significant difference. 78% of the FASD population had significant mental health problems as opposed to 56% of controls. Same problems at a much greater rate. This is a significant need profile, and again, speaks to the necessity of intensive interventions to address the multiple needs that exist for this group. They also have, as we heard from Dr. Rasmussen this morning, as well as a number of other speakers, about the neurobehavioral deficits. These are some of the underlying issues that contribute to this risk profile. So in addition to more likelihood of having mental health issues and abuse, this is a population that also has underlying brain injury that contributes to impulsive behavior, inhibition. We heard Patricia talk about some of the things that contribute to why an individual may offend in terms of sensitivity to touch and not understanding the situation that they're in. All of these variables are part of that neurocognitive profile that increases the likelihood and the risk that somebody is going to reoffend, and those needs have to be understood as treatment needs for a this population within the criminal justice system. School and employment failure also exist for this population as much as they do within the general population. Finally, we get to the responsivity principle. This is the principle that speaks to how do we provide treatment? How do we do this? So we know what the risk level is, so we know how intensive that treatment is. We know what the needs are, so we know all the different areas we have to target in. And with FASD, high intensity, lots of needs, so we're covering the gamut here. How do we go about doing this? What is the actual cognitive profile of this individual that will help us to decide how to best tailor or consider the best intervention approaches? Remembering, as we started, that just doing an intervention doesn't mean things will get better. We can do bad interventions and we can make things worse. So we need to be thinking about what we're doing and thinking about this principle. Ironically, although this principle is so important because we can make things worse if our how is the wrong how, and we do the wrong thing, it's also the least researched of all of these principles within the justice system and within the literature in the area. The least amount, because it's the most work to actually study whether or not a treatment program works, is the most expensive and the most difficult part of working within the justice system. And yet, it's the work that we're most desperate to have. We need empirically supported interventions. What that means is we need to be able to do research that tells us, is this actually making things better, and how do we know, and what is it making better? And by doing that kind of research, we're able to continue to evolve those strategies. One size does not fit all. A study that was done, this is a seminal study done in the 60s, and what they did is they looked at a couple of groups of individuals within the justice system. This is not within the FASD population. These were just two groups, and they did some cognitive testing, and they said this group is high functioning and they're really verbally capable, and this group is not. They're lower functioning and not verbally capable. And then they put them into a psychodynamic treatment, which is a treatment that says, let's think about what you did, let's think about what you did wrong, let's think about how you can do it differently, let's talk about how we want to change your behavior, let's have some insight, and from that insight, change your behavior. The group who were bright and verbally intelligent saw a reduction in offending behavior. So they went on, and the evaluation of that, the empirical evidence from that, was that they offended less. They went on and they did better. However, the non-amenable group, or the group that had lower cognitive functioning and lower abilities, not only didn't get better, but actually showed a slight increase in offending. Things did not only get no better, but possibly worse. So this means we need to think about the approaches we're using. One approach will not work for everybody. We know that certain aspects of the brain are negatively affected by alcohol, and that those things affect the ability to respond to negative feedback and learn from consequences. Dr. Rasmussen spoke about some of the executive dysfunction that we see in the FASD population. So we know that when we use the classical operant approaches, which are the approaches that say, I am going to reinforce good behavior, I'm going to reward you for good behavior, and I'm going to punish you for bad behavior, don't work for populations that don't respond to reward. So if you remember Dr. Rasmussen's talk from this morning, she talked about some of the tests that were used, the executive functioning tasks, where the typically developing kids actually showed that with reward and reinforcement and punishment, they learned how to optimize their rewards and do the very best they could. But those kids who were NFASD affected, they demonstrated no learning curve. So based on whether they were getting a reward or they were getting a punishment, they were unable to change their behavior. So utilizing approaches that are reward and punishment based exclusively within the justice system are not necessarily going to be effective for this population if their ability to understand and respond to reward is compromised. We have to rethink it a little bit. As we already talked about, or Dr. Rasmussen already talked about the significant EF, I'm not going to go back to it. Responding to executive function, having said all of this and talked about it within the FASD population, I do want to come back and say that we know there's a connection between poor EF, poor executive function, and delinquency, but this is not just because of the FASD population. We know there's unique contributions within the FASD population, and that there's a unique constellation there because of the sheer extent of the problems. But it's not unique, and there's a large number of offenders within our justice system who also present with EF difficulties or executive functioning difficulties. So what that means is, and we were talking about this just previously, is do we have to redefine the entire, or do we have to come up with an entirely different system for FASD alone? Or do we look at how do we reconceptualize the system to be responsive to different needs, whether they're high functioning or low functioning? FASD may not be the only ones who benefit from an alternative conceptualization of how we provide treatment approaches within the justice system. There are likely other populations that would similarly benefit from these same approaches. So some of the recommendations I have that are based on these pieces of information. Given the high risk profile of the FASD population, we need to be prepared to allocate sufficient resources to meet their needs. And that means a sufficient intensity of treatment across multiple domains, recognizing that their needs are many and that their needs are high. We need to recognize that an understanding of the profile of brain dysfunction with this population is an important part of conceptualizing what their needs are. We need to know if this individual has a type of brain injury that impacts their ability to inhibit their behavior. If that's the difficulty, then how do I develop inhibitory control in an individual? Telling them to change their behavior isn't going to work if they just simply don't think before they act. They're going to continue to think, just simply act and not think. And then afterwards, they're going to go, oh, wait a minute, I was supposed to think, and I forgot, because they're jumping into it. Or an individual who can't regulate their own behavior, can't regulate their emotional state, is simply going to be agitated and worked up. And unless we teach them, how do I regulate my emotional state? How do I downgrade this emotional reaction? Whether or not they understand the rightness and wrongness of their behavior is not going to be relevant. If I don't know that when my body gets tight and my shoulders are up around my ears, that means I'm getting agitated and I'm about to be angry, that I may not be really good at recognizing the clues that I need to go and start deep breathing. I need to use a relaxation strategy here. So once we start to understand these fundamental needs, we may see people who can bring down that agitation, as opposed to simply saying, if you have the knowledge, you can change the behavior. No. Sometimes I need to change what's happening in my body or change that reaction a little differently. An expanded clinical understanding of these needs will help us to capture that significantly higher number of needs and the interaction between these environmental pieces, clinical pieces, and cognitive pieces. We've heard a lot of talk today about the fact that even though we're talking about brain, we're also talking about a large number of environmental pieces. And this is a population with a brain injury compounded by a large number of environmental factors that are also contributing to what they're dealing with. Responsiveness to risk and needs must support function-based approaches to treatment. How do we change function? How do we change behavior at a fundamental, visceral level, as opposed to working from the knowledge base that may make sense to the rest of us? We need them to be appropriate for cognitive functioning, geared towards the cognitive functioning of an individual. If they're not explaining the way their rights are being explained to, they're not understanding how their rights are being explained to them, as Patricia pointed out to us, which happens so often, then how on earth are they going to understand what we're talking about in treatment? They're not going to get that. We need to get things a little bit more basic, fundamental. This can entail building on existing approaches. We don't necessarily need to throw the baby out with the bathwater. We heard earlier today about some interesting intervention efforts that are going on, and I think there are some neat things that are happening within some of the correctional system in different places. So there are certain things we can begin to build upon. We don't need to throw it all out, but we have to be conscientious about what we're doing and what we're building on. We also need to look at increased support through the adolescent-adult transition period. So we need to look at how we are supporting individuals effectively through that transition period. This is a population that is affected in so many different ways. They are going to struggle to navigate that system. One of the really crucial pieces, and I think, Patricia, again, keep going back to you, Patricia, you laid it out so beautifully for me, is looking at building partnerships with community-based health and mental health systems. So justice system doesn't have to operate alone. And as Patricia was talking about the importance of, child assessments or assessments and information that comes in, that we're not looking for the justice system to do all the work, there needs to be a strong amount of reciprocity between children's services, the justice system, the education system, the health systems. There needs to be ways that we're working together. The justice system cannot operate alone to meet the needs of this population. The level of complexity and intensity of needs is too great for one system alone. We need more research. We need longitudinal research that helps us to evaluate whether or not the efforts that we're putting in are working. If we don't get to follow these folks, we don't know what's working. We need to know if the treatment approaches are having a positive outcome. And we need to know what are the exceptions. Show me the individuals out there with FASD who are doing really well. I want to know why they're doing well, and I want to know how we can replicate that. Let's study those exceptions. That's going to help us build on those learnings. Let's look at training. We've heard a little bit about training. We want training that supports understanding. And when I talk about training, I'm not talking about 3 hours of an afternoon and now I'm FASD knowledgeable. I'm talking about the kind of training that actually change and impacts practice. which has to happen over a few months and which has to involve learning and reflection and change in behavior and actions. That's hard work, and it doesn't come easy, and that kind of training is necessary. And that, in a nutshell. Ooh, look at that, with 23 seconds to go. Oh.
Thank you. Are there any questions from the jury? Bill Robinson.
Well, thank you for that great presentation. I'm thrilled. I'm thrilled to hear you talk about training at the front end. With my background, I can tell you that I came across many hundreds, if not thousands, of poor young people who, quite frankly, weren't coping very well. And I think that we've talked earlier today about training social workers. We've talked earlier today about training treatment staff and hospital staff. But I really think that we need to focus on training our police officers. We do such good work right now in training them on things like suicide prevention, things like at-risk behaviors and mental illness issues. But FASD remains that one piece, in my view, that is left out. And of course, if we don't train them, you know, our officers go blindly forward without the knowledge and the education, and they continue to pump folks into the system with no regard or concern. So I'm very pleased for your comments today, and I would encourage, I guess I would encourage us all to make an attempt to put this training right on the grassroots front line so that we can see some real impact. So thank you very much.